Hi, everyone. Welcome to today's webinar on quality, safety, trust, and responsibility in AI in healthcare. I'm Lisa Silverman. I'm URAC's client educator, and I'll be your facilitator for today. We're going to get started with just a couple of quick housekeeping announcements. You all are pros at webinars. You've been behind Zoom for 5.5 years now and longer. So if, though, you're having any issues, I don't know what happened there, message Nick Davis or Lauren Hammett. They can both be helpful with any issues if you're not hearing sound or anything like that. You all have started using the chat box. You'll see we don't use a Q&A box. We only use the chat box, and we keep track of the questions in there. We want you to share your ideas in there. We're going to put resources in there. So look for Laura Wood to be popping in resources there. She'll share links to things. And yes, we are recording this webinar. And yes, the slides will be sent with the recording next week. Also, just as a note, if you are chiming in with an AI chatbot, we are going to remove that chatbot. We will not remove you, but if it's noted as your chatbot, we will remove the chatbot. So just so you know, that's our policy at URAC. So here's our agenda for today. We're going to do some welcome and introductions just so you know who's who. We're going to cover the current state of AI in healthcare, and then we're going to talk about why quality, safety, and responsibility are so critical. We're at this important point where we can see really good, but we could also see some challenges. And then we're going to introduce you to our new Healthcare AI accreditation that we launched. So before we get started, let me tell you who our presenters are today. I've got Deanna Harden. She's with us at the URAC team. She's going to be, for most of you, your first point of contact if you're interested in our Healthcare AI accreditation. I've got Jen Richards, who's our Senior Director of Product Management at URAC. I have Dr. Shakira Grant, who's the Chief Executive Officer with Cross Global Research and Strategy. And I've got Dimitri Yanni Kapalis. I did not say that correctly, but I really tried, Dimitri.
Thank you, Lisa, and thanks for the introduction. It's nice to see, like Lisa said, a lot of familiar faces, a lot of new people, and I'm so excited that you all could join us today for a discussion of AI in healthcare. I'm Deanna Harden. I am the initiative lead for digital accreditations here at URAC, and I'm just excited to have a chance to have a discussion and hear feedback from people in the industry. Next slide. For those who may be new to URAC or sitting with us on our first webinar, I just wanted to go over a few highlights about who we are and what we do. We just recently celebrated our 35th anniversary last month, actually, at URAC Connect, the event Lisa mentioned earlier, which we hold every year. It's really great. So some of our accredited clients, our partners, and other people in the industry were able to be there with us to celebrate that. So that was really exciting. Another thing about us is that we are really big on education, and we feel like through education comes growth. The more that you know, the more you're more comfortable, and which leads to quality improvement. Another thing, we understand that there are so many different organizations that have and use AI in different ways. No matter what the program accreditation is, we understand that excellence looks different in every organization. And we're appreciative to the partnerships also that we have. Next slide. Another thing about URAC is we have approximately 40 plus programs. Jen could chime in on the exact number, ranging from health plan to case management to to pharmacy to digital. So whatever you may have a need for outside of AI, we can be accommodating to any kind of program that your organization may see a need to explore. So we're happy to help with that. Next slide. URAC's approach. So this goes back to the connect that I just mentioned. We love to educate people. We love to build trust where we can serve in a setting where we provide subject matter experts to help. You can sit and get feedback from a reviewer, and it's a collaborative approach to understanding accreditation, which builds trust, that helps feel more comfortable about meeting the regulatory requirements that your organizations need to meet to be in compliance. And with that, I can turn it back over to Lisa, and I think that we'll just get right in. Yep, Dr. Grant.
Hi, everyone. It's a pleasure to be here, and thank you to the URAC team for the kind offer and invitation to participate in today's webinar. I'm Dr. Shakira Grant, and I am a physician board certified in across four specialties. But my current role is as the CEO and founder of Cross Global Research and Strategy. We are a company that helps to co-design and co-develop AI technologies with health tech builders from early stage startups all the way to big tech, advising to ensure that AI tools are equitable as well as have the relevant guardrails and safety to guide the implementation and adoption into healthcare settings. I'm also a former policy advisor in the US Congress on the Ways and Means Committee, where I helped to shape the policies for Medicare beneficiaries in the US, as well as lead the committee's AI portfolio. Next slide. I talked a little bit about the four pillars of Cross, but this slide just really goes into it in a little bit more detail. Cross is anchored on co-creation, offering AI advisory and strategic support, as well as AI governance, which we'll talk a lot about today, and AI ethics. When I speak about AI governance in particular, this is the guardrails and policies that are necessary to ensure that AI is developed in a way that is safe and trustworthy and also deployed in such manners. Ethics, as we all have heard before, this really spans the gamut of embedding equity, transparency, as well as accountability. And together with these four pillars, Cross helps to move innovation into the hands of patients and physicians and clinicians who need to benefit from these technologies the most. Thanks so much.
Hi, I'm Dimitri Yanikopoulos, the Chief Innovation Officer at AI. It's a pleasure to join the panel today. I've been in healthcare technology for about 20 years and seen amazing transformation, most recently with artificial intelligence, particularly in the radiology space. RAD AI is a radiology-based artificial intelligence solution that works directly with the radiologist at point of care for interpretation. So what we initially started doing was automating the bottom third of their report, the impression, which is the area that a lot of ordering physicians and patients will look at to identify what happened, during their encounter. We have been deployed across over 9,000 radiologists, nearly a third of all radiologists in the United States, covering over 200 different organizations and about 60% of all institutions in the United States. There's been a lot of recognition, not just within the healthcare industry, awards like Aunt Minnie or class recognition, but also more broadly, given the high degree of impact and opportunity of artificial intelligence, specifically on radiology. We've been doing this now for about 7 years, long before it was called generative AI. One of the first use cases, and potentially even the first use case of Gen AI in healthcare, back in 2019 with that impression generation. We now deliver a complete radiology reporting and interpretation solution as well, so that radiologists can rethink the way that they approach that documentation step, and how that can be used to enable their workflow as well as precision medicine pathways. Next slide. One I want to specifically highlight is the recent recognition from Class Research. We were up there with Oracle, Epic, Microsoft, and Workday, multi-trillion-dollar companies, as being recognized as one of the key projects of artificial intelligence that CIOs and healthcare system leaders at over 200 different institutions were looking at. We Like to say that this isn't entirely about us. As one of the earliest Gen AI solutions, that has been important. But radiology in many ways is the fulcrum of care. There's a high likelihood if you go into a hospital, you're going to have imaging. If you're coming out, you most likely had it. So being able to impact that with this new technology is really exciting, and it was a pleasure to serve on the AI Accreditation Advisory Board. I learned a whole lot about accreditation processes. Thank you.
I'm on. Thank you guys for joining us today, Shakira and Dimitri. We really look forward to talking through. So we're going to go through the current state of AI in healthcare. Before we do that, I did want to mention both Shakira and Dimitri were sitting on our advisory group as we developed our program. And so, while we are experts in accreditation, we really leveraged the organizations that sat on our advisory group to help us create a program that was not only the best it could be, but also relevant to the industry, usable across different platforms, and we were able to really come out with something that I think everybody is kind of proud of. So we'll go through the current state of AI in healthcare, and then we'll start to dive in a little bit deeper into those, into the development process and the standards that we came out with. So our current landscape, what we were seeing even before we started looking to develop the program was there was a huge lack of clarity and transparency about the use of AI. Patients and stakeholders were not fully understanding how and when AI was used in their healthcare. In fact, there were so many people that had no idea that AI was being used in their healthcare. And some of them were providers who were using AI unknowingly within their processes. There's a huge amount of uncertainty around statutory and regulatory requirements. That remains the same today. We see that continuing to evolve, whether it's state regulations or federal executive orders. All of it is constantly looking at AI in a different way. And there's a huge amount of uncertainty as to where that is going to land in the future. Above all, throughout all of this, there was also that underlying pinning that AI naturally needs to allow for flexibility and adaptability within the industry and within specifically within the AI industry, not just healthcare. And so looking at how can this all come together, what can we do to really help us be able to move forward in this industry, allowing for guardrails and allowing for that flexibility and adaptability as well. In the end, we saw AI is transforming healthcare. It continues to transform healthcare daily. And there's still a need for trust, accountability, and safety. And that continues to grow as the technology continues to evolve as well. Dimitri, Shakira, anything you guys want to add on that before we dive into systems and the types of systems there are? Awesome. All right. So when we're talking about AI systems, there's two different things that we're talking about, and we really had to be very careful in our language because we can be talking about different types of technologies like machine learning, deep learning, natural language processing, or we can even be talking about purpose like generative, predictive, assistive, conversational. And so we see that or the AI system language is continuing to evolve as well. There's new terminology that is being introduced all the time, and there's new ways of using AI. We started out with machine learning and really starting to understand how that was helping and how that was playing out. And then they introduced deep learning and natural language processing and things like that. And it continues to evolve. Dimitri or Shakira, do you want to add in for systems? Anything you have to talk about?
No, I think
Anything
that
I missed?
there's a lot, but that's
Yeah.
this is a good overview. And I think
Yeah,
that's part of the challenge of these conversations, right?
for sure. Yeah. So, and we talked a lot about what do we mean? What does this term mean when we're talking about it? Next slide for me. So There's also this AI use cases concept. So, how is AI being used by providers and with patients? So some of the major ones that we're seeing, I pulled out just so that we could kind of talk through them, and you could see there's so much happening here. And so a lot of where Dimitri was talking about is in the clinical decision support area, like radiology and cancer screening. Shakira also talked about this in having, protocols and things surround guardrails surrounding how you use AI in cancer outcomes. But we also are seeing things like patient chatbots, where it's a technology speaking with the patient directly, or patient scheduling. Behind the scenes, the patient doesn't even know that this might be happening, but they're being scheduled by an AI system. And then a lot of us are starting to see visit transcriptions happen as well. So you'll be asked in a physician's office, is it okay if we transcribe, if we use AI for transcription? Use that.
I'd be curious to know from the audience a little bit of who's hearing this when you even go to an appointment. I went to an appointment with my primary care maybe a couple months ago at this point, and she said, "Do you mind if I use AI for?" And I was like, "I don't know what you mean. You're a new doctor I'm meeting. I don't know what I'm gonna say, right?" And like, how many of us have those moments where it's like, "So I'm gonna make a quick decision right now, right?" Like, and then Laura, my wonderful coworker here, and I told her about it. She said, "Well, did you ask what they were using it for?" And I was like, "No, I was so caught in the moment." Like, and think about that patient who's at that vulnerable stage. Kira, I think you can talk about this and that patient in that, like, wait, here's somebody I'm supposed to trust. What are they doing? Can I trust this? And Laura said to me, "Are you going to ask what they do it for?" So the next visit I went and said, have you, what are you using it for, and kind of getting that clarity. So I think there's even some of this as we talk about responsibility of like, what is that responsibility? Shakira, I'm going to put this on you here as I'm going to interrupt her a second, but like, what is that responsibility of the doctors and the providers, so they don't catch somebody in the moment? And I'm somebody who works in healthcare who's pretty intelligent.
Yeah. Yeah, I like this example because I can say that I had that also happen to me, even though I'm a physician. And during my primary care physician visit, where I had already been roomed and everything and just about to sit down, and we had started a conversation, my primary care provider then all of a sudden interrupted and said, "You don't mind if I record this conversation to help with my notes?" And so I too was taken a little bit aback because while I knew about the use of this type of what is known as ambient scribe technology, it felt as if it came a little bit late in the visit. And so I would say, we have a responsibility as clinicians, as healthcare providers, to ensure that our patients are informed ahead of time about AI use within their healthcare. And I do acknowledge that it is very difficult to disclose exactly where AI may be in use because there are some back end systems, like for instance, in radiology, or even how you will get paid from an insurer where AI systems are used. And so it's maybe difficult to describe exactly all the areas. But in this particular use case, I would strongly advocate that if ambient scribe technologies are being used in the visit, that this should be disclosed at the time of checking in, for instance, and at least giving the patient the option to opt in or opt out to have their visit recorded.
Yes. Yeah, I think that's so important there, that opting in, but also being clear of like, would you mind if I used AI for X?
Yes.
Right. And, even to say it, like, even just that one liner, and you have that patient, who knows if they're robed, and you said they're in the room, but if they're robed already too. So, do you mind if I use it for X? It's only capturing voice, right? Because suddenly it's like, oh, wait, is there a camera in the room? So, I think even just saying that, and if you're doing it, we have a lot of pharmacies on here, health plans on here. So, I think that speaks to those other ways of like, we're doing the same with when I open the webinar. I'm recording this. It will be
Mhm.
shared among participants, anyone who registered.
Yeah.
I do think it opens up a challenge in how do you actually apply some of these desires. Take, for
Hmm.
example, if somebody opts out of any use of AI in their care experience, ambient dictation, understanding, recording, that makes sense because it's, something that's happening right there in the moment. But behind the scenes, potentially AI could be used to triage your case to a higher priority. And that's a benefit generally to that, individual patient in that situation. based on uncovering that information. So it's hard to define that, which is why I've seen it a bit more showing up in those initial intake paperworks, and it might be Roman
Mm.
numeral 45, sub
Yes.
3 is part of the challenge there with these days. But I think AI is used much more than we all consider in our healthcare experience today.
Mhm.
In radiology, for example, over 1,000 cleared, FDA cleared image-based algorithms at this point. If you look at the documentation side, you know a third of all reports in the United States are touched by this kind of stuff. So it is happening, and I think we all have to kind of get used to it to some degree. It's the way that you type. It's just how the physicians use it that is the most important
Right.
part. Are they using it to assist, or are they using it to? They're not at this point using it to perform the care, as an example.
Right.
So
Right.
having that
Mhm.
understanding is key.
But we see a couple of questions in the chat here. Somebody's, and I think we can poke at this a little bit, of do we think AI is going to be added to the HIPAA releases or any additional sign off or, federally mandated AI watermarks and disclosures? Is it something that, like, when I make that appointment, somebody has to say to me, just so you know, our practice uses AI for X reason? Like, at where and when does that happen? And where and when does it happen? Not just, I realize we have a lot of pharmacies on the call, and we have a lot of utilization management and um, health plans on the call as well. So where along the way, I mean, we can see where it happens in direct patient care, but what about in those indirect patient care examples as well? Jen, do you want to start there? You're nodding.
Yeah, I mean, this is definitely a conversation that continues to evolve in, where is this, where should we be including AI within different release forms, different disclosures, different ways that we let patients know. Um, and a lot of the things that we discussed with the advisory group were risk-based type of disclosures and how that disclosure came out through the risk, as more of a risk assessment of impact to patient or impact to overall patient safety. And so, you know, I think in general, if it's HIPAA related information, it we are seeing some of that come through HIPAA forms. HIPAA forms are generally pre-done. They're copied from
Mhm.
somewhere,
Yep.
and we're not, it's not standard that it's in HIPAA forms right now. That's not a
Right.
requirement necessarily. So,
And I would just pick up on that also and say this is new territory that we are navigating. If we level set and think about when HIPAA was passed in 1996, it definitely was not at the stage where we are at currently. Even though AI has been around since the 1950s, we've seen an explosion
Right.
from 2022 with generative AI and the computing power that we have right now. And I think when we think about consent and where that should lie, we do all recognize with the increasing use of AI. And I will take a moment to say, especially in the utilization management, in areas such as prior authorization, where we're seeing cases making their way through the legal system right now with AI algorithms that have inappropriately denied care for older adults on Medicare
Right.
Advantage plans, that there is a need to think about how do we enforce transparency when AI is used to make these decisions, and how do we best communicate that to the stakeholders involved. And so, from the direct patient care experience, I think we have an opportunity here where we can have a blanket statement potentially as patients are engaging with the healthcare system, just as a disclosure to say, AI may be in use at various points in your interaction, and maybe you can use 3 or 4 high level touch areas to disclose to the patient. But as far as informed consent for AI use across the healthcare continuum, I think that will be a bit more challenging for the reasons that Dimitri identified. But I do agree that we need more transparency, especially when these tools are being done and when it has the potential to harm other populations.
Yeah, for sure. And so, I mean, that's a really good segue into the impact of AI use in healthcare. So, we're seeing two different major impacts. So, of course, there's the patient. We want the patient to be front and center, and we want them to be the highest level of priority in safety and transparency that we can possibly get to reasonably within the system that we're in. So, when we're talking about personal data or clinical outcomes or time with clinician, patients are concerned about these things and how AI is impacting each of these things. How is my personal data being used and where is that use happening? Clinical outcomes, is this system going to drive my entire care? Is that going to impact the outcome of my care? And how is that going to impact my future? And then time with a clinician. So we've already heard a lot, well before AI. We heard, it's harder to get time with a clinician. It's harder to be in the office with them, and for you to feel a connection and have that patient-provider relationship. Physicians are moving faster. They need to move more people through, and they need to be able to talk to more people in a day to make sure that we're covering the entire scope of our population, even. So using AI may actually create less time with physicians if they're using AI to enhance their efficiencies through those appointments. And so, or the opposite side of it, you may see that patients are more willing to speak to their patient or to their physician because the physician doesn't have heads down typing the entire time. And so maybe they're having more meaningful conversations. We don't know. We don't know how any of this is going to play out right now. On the system side, looking at.
Jen, hold up. Hold on.
Go ahead.
We're gonna pick at this a little bit
Yeah.
more here because there's good stuff on the patient side and there's good questions coming in from the chat box. So I want to, and I know I have a really smart group here, so I'm gonna kind of ask us to tackle this in two ways. I'm thinking about the sensitivity here. Patient sensitivity and things like confidentiality beyond that, beyond what's being shared. So let me give two kind of aligned in some way instances. Shakira, I know this is yours. Dimitri, you can cover it too. But I want to talk about one, mental health. And then as we move from that, kind of evolve from that and what's a sensitive area, also talking about DEI. And I'm not afraid to use those words. Let's call them diversity, equity, inclusion, and belonging, and making sure that as we're being sensitive to one, we are also recognizing the challenges with other. And Dimitri, I think we've seen technology, even we know technology has challenges. We've seen it with darker skin. Let's call it out for what it is with blood pressure readers, things like that. But let's start on mental health and maybe move that in. I think they align together. And I know this group is really smart and can talk about them together. So let's think about that on the patient. Who wants to dive in? Shakira, I see you're
Oh, sure.
smiling.
Sure. I was gonna let Dimitri kick it off since I had kicked it off the last time, but I can start a little bit about mental health. I think this is an area where we're seeing the explosion of AI use, especially as it relates to AI chatbots being used as potential therapists and really helping to guide patients through their mental health or emotional or psychological needs. I think one challenge that we have to be careful with the use of AI in this way is we need to recognize and call out AI as it is not a human. It is not meant to replace a human. And whether or not we are doing a disservice to those who are seeking mental health services by creating a loop where people are becoming more and more dependent and emotionally attached to an AI system that is really computer-driven algorithms. Again, I will point to the legality around this, not from a lawyer's perspective, but because this has gained a lot of attention recently. And the case against one of the large LLM builders, where a teenager, committed suicide. And after his death, unfortunately, it was revealed the intimate conversations that the child was having with the chatbot and disclosing a lot of the suicidal ideations. And there's questions as to whether or not the information or the responses were truly relevant. So I will say, I think we need to have a measured approach if AI is being used in mental health, and it needs to always have a human in the loop and not think of AI replacing completely mental health therapists or other mental health professionals. I'll turn it over to Dimitri.
When it comes to mental health specifically, I would agree. There are other use cases where there may not be, direct physician engagement with the diagnostic process. If we look at the modern tranche of FDA cleared algorithms, it was for, diabetic neuropathy, I think, and I don't know, it's in that space, but it was, independently cleared with no direct physician integration in that example. But generally, particularly for something as sensitive as mental health, you would want a human in the loop to appropriately triage and coordinate the
Yes.
information. I would also like when we look at things like children interacting with those tools, there are already existing frameworks and laws. COPA is has been around for 15 years, I think, if I remember correctly, plus. And, it covers that engagement of children with tools online and, with the intent to protect them in those situations. So I think it's really important to not entirely reinvent everything around this just because it is AI. It's more reinvestigate and reconsider how that's going. And I will add, there kind of isn't a choice. It's not if, but how are we going to use AI? If you look at the availability of medical practitioners, and mental health isn't a great example of that, where there's a limited supply of individuals that can deliver those services, and up until recently, it wasn't always covered by insurance, right? So how do we open up the ability to have those folks operate more efficiently, spend less time on pre-reads, instruct them on the way that the AI is enabling it, and offer clear paths for provenance. Like that's where a lot of the ambient scribes and like us on the reporting side with the radiologists make sure that they understand this is where your data was stated. Here's how it was interpreted, if it is interpreted, and placed, so that they can clearly see that without having to just trust, that it was correct.
Yeah.
Then
Yeah.
one last thing about so Jen, if you mentioned this earlier, like population's increasing. If you look in the next 30 years, it's going to increase by about 8%. But if you look at the complexity buckets, and I will be in one of these buckets by that point in time, the 55 plus age group increases by like 150%. The 90 plus age group increases by 300%. So, it's going to become much more complex for physicians that currently on average get less than 7 minutes with their patients to actually work with them. My wife is a primary care nurse practitioner, and until she became one, I didn't realize that when I went in to see my doctor, I was seeing them for something. I thought I could kind of talk about everything, and unless it's my physical, that's not the case. So, I would show up with the laundry list of problems, and they'd be like, "No, what's wrong with your knee?"
Right.
And,
I
so
learned
I think it's
recently
going to
that
be
like you go in and I thought physicals were like go in and bring me your concerns. That like didn't warrant an individual visit, but then I learned, oh wait, the second you bring up a concern, it turns into a sick visit.
Yep.
This is interesting stuff that I don't think the general population, I think many of us on this call would be aware of this. This is really interesting. This comment from David, I think a couple of people have seconded it here, of clinicians needing to be aware of how the AI models are built, whether you're a clinician, a nurse, in a case management, in a community health worker, even just having that awareness and just being aware of the biases and kind of checking them and saying the what abouts, kind of what about this? What about that? And vendors and organizations have to be aware of that. So, David, I really appreciate that comment there. And Brenda points this out here too. So, we have AI. So, AI can analyze the data, and AI can take these large data sets and do wonderful things with them. But we still need the brains. And I think we've talked about this, Dimitri, you brought it up too, of like, we still need that human
Yep.
Yeah.
behind there.
So if you look at FDA cleared solutions, they have to give an indication for use, and that's AI, that's pharmaceuticals, whatever. Like, it has a very clearly like discrete indication for use of how that should be applied. AI is no different, FDA cleared or not. It needs to have clear instructions on what it's doing, how it's doing it. There are varying degrees of disclosure, that need to happen. You don't want to overwhelm the end user, but you want them to have a good idea of what's going on. So that's where a lot of model cards, as an example, are starting to fill that niche. I serve on the CHI model card definition committee, helped build the original model cards out of that committee, and that's kind of what they're meant to provide. It's not the super in-depth documentation, but the high level. However, I don't expect that a nurse or a physician, leveraging a solution will necessarily pop that up every single time. um, I was at a meeting on Capitol Hill, and the former director of OCR was there, and she stated that bias does not equal discrimination, and that kind of blew my mind at that moment in time. This is a few years
Yes.
ago. But you can develop a bias algorithm. It's how you use that bias algorithm that
Mhm.
ultimately determines whether or not it's discriminatory. If you're widely applying something, then it could be. If you're applying it in a very tailored way based on specific indications, then it's not. It's just appropriately targeted. It's providing that precision medicine pathway that that individual needs, based on the relevant factors.
Mhm. Yeah.
So we are going to get into URAC standards a little bit and how we have played through some of these discussions that we are having right now. We outlined some system impacts as well. And these, again, everything is moving constantly. So while these are things that we're seeing being impacted today, this is not a comprehensive list, and it is not going to remain this way exactly as is tomorrow. So, we are seeing financial stability, updated payment models. We're seeing efficiencies being built in. We're seeing systems have to deal with data security in a way that they've never had to deal with before. And so we're just seeing that there's so much movement, so much impact. And really, our goal was to create systems and processes and frameworks to be able to guide people through the use of AI in healthcare, and not necessarily, become too prescriptive in what we're doing. Um, so, so real quick, I'm going to have you go back, if we can, couple slides. Yeah. Sorry. Go ahead on to the next slide. So before we dive into the standards, so one of the major things that we talked about in the AI advisory group was how do we address quality, safety, and responsibility. And so Shakira and Dimitri, I'm going to give you just a couple of minutes to come at it from your angles, and then we'll pull it together into the AI advisory group in just a second. So go ahead.
Sure. So I would say in talking about this in the group, is one recognizing that while Dimitri and myself, we are on the panel here today, that this was a concerted effort with many different experts across different disciplines that came together to share their real world expertise. And that really helped to shape the standards overall in the different domains that we focused on. And some of them we'll get into as we talk about ethics and safety, bias and transparency, and how we defined those particular metrics. But I think the key is to recognize that these were based on a cross-functional team and collaboration working together to help define these key metrics.
Agreed. And the conversation, I think, was really vibrant as a result of that. And one of the areas that I took away, not having as much experience with accreditation in the past, it wasn't about making a direct statement, do not or do, as something. It was more about evaluating the framework and the processes of that individual institution based on their specific needs and how they're considering this. So I found that, particularly when you look at quality, safety, and responsibility, make sure it's aligning with your guidelines, with your protocols, with your med exec committees, pathways, different things like that, to be, quite helpful, because this is moving so fast. And anything we come up with today that's perfect will likely not be perfect by tomorrow. So having that, framework, I think is important because it gives, sites the ability to think about how can they actually apply this.
Right. Awesome. So taking all of that and going into our healthcare AI accreditation. Next slide for me. So, our objectives in developing an accreditation was to provide a framework for developing and using AI in healthcare. One of the things that we talked about early on is, we came into this area thinking, well, users, the healthcare providers that we have a lot of connection with and we deal with consistently day to day, those are our client base generally. They needed a framework for making sure that they could use AI appropriately in healthcare. And what we heard very early on was, yeah, that's great. That sounds awesome. But what about the developers? And how do we assess a developer and make sure that what we are receiving from a developer can really help us grow and succeed with our use of AI in this healthcare practice? We also were looking to promote quality best practices for the industry, allowing innovation with that appropriate guardrail for patient safety. And then also seeing that there was so much compliance and regulatory requirement changes and movement throughout all of AI, whether it's state again or federal. We wanted to be able to promote compliance with regulatory requirements. Not necessarily say this is the regulatory requirement, but how do you manage that? How do you help yourself remain compliant as the changes occur? And then from our standpoint, we went into this understanding that developing a version 1.0 accreditation in AI in healthcare was going to be a learning process, not just while we were developing it, but immediately once we release it. What are we hearing? How are we being received in the market? What changes are happening? How is the industry continuing to grow and change? And do our standards continue to remain relevant? So we wanted to continue to learn even after we released the program. Next slide. And so to Dimitri and Shakira's point, we had so many people on the advisory group, so many different organizations on the advisory group. And really, our goal was to set out an advisory group that could talk all the way through the different areas of using or developing healthcare AI. And so we have policymakers, we have users, we have developers, we have payers, we have so many different organizations. We have legal firms on here as well, and really this helped us create, again, to Shakira's point, this helped us really have a robust conversation about what does it mean to be using or developing AI for healthcare, and how can we put those guardrails in place to protect patients and to make sure that providers and users are adequately informed without stifling innovation, without stopping the industry in its tracks. Next slide. And so some of our lessons learned, and then I'll pass it over to Shakira and Dimitri also for lessons learned, because these are my lessons, our lessons from URAC that we learned from you guys. And so there are so many lessons in here. So we learned the developers and users have different quality focuses. Again, seeing that there was that difference between a developer who is developing AI and then those who are using that developed system. And then when we even get into it, looking at the developer group and the user group, even within those groups, they were not created equal at all. There were huge variations in the types of systems that were being used or in the types of use cases. We learned that not all biases are bad. This was a really good point that was brought up multiple times in the advisory groups. Patient confidentiality is a gray zone. We do have HIPAA, and we have what that means from a data protection perspective and the protected health information. But when we were talking about, okay, so how can that be used within a closed system versus an open system? And there's so much conversation that we can get into here. And really, we wanted to protect confidentiality or patient information as much as possible and came out with a more broad perspective of all patient information should be confidential in nature. And then also transparency is defined through specific practices. We started this conversation with the AI advisory group saying, okay, we want a focus area in transparency and we want standards around that. And we got towards the end and we're like, oh, all of the standards that we put in support transparency. And that's really the practices that matter in order to get to transparency. So those were our lessons. Do you guys have anything else you want to add before we get into standards?
Yeah, I'm mindful of a little bit of the time here, Jen. So I wanted to
Yeah,
kind of
go.
take us a little bit off course here a bit because I think these are questions that had come up in the chat about bias. And I wanted to just take a moment just to talk about that. And then there's another question here about patient representatives and whether that was represented in the committee. And so maybe I can then pass it on to you, Jen, and then Dimitri, you can talk a little bit about the radiology perspective a little bit more. But from the bias perspective, I just wanted the attendees here to recognize that there are multiple points in which bias comes up within the AI lifecycle. Oftentimes, we think about bias in the data set, thinking about the type of data that the AI model is trained on. That is definitely one of the major sources, but there are other areas. So you want to think about the way that data is actually labeled when it's being used and prepared to be entered into a model. That is a way where if humans are labeling the data, we can see potential biases. The example I like to give in this case of how biased data and bias can result in bias outputs is as an oncologist, when there are tools currently on the market being used to diagnose skin cancer that do not perform as well in people with darker skin tones. So you may ask yourself, why is that? Well, the reason is the model was trained on data that did not expose it to darker skin tones. And so in the real world, it's not able to pick up that skin cancer. So that's a form of bias. The other aspect we need to be aware of is when we team as humans with AI and we get outputs that seem to be counter to what we as humans would do, we have to recognize that we all have our own biases too. And that is another area where human bias could then compound what the AI system is doing. And then the last part, when you think about bias, is more along the lines of access and fairness. So, who actually has access to the AI tools? And I can tell you that the way that AI innovation is evolving in the United States, that this is not equitable. We see differences within the US where those who are in resource settings that can afford these AI systems and the monitoring that needs to go along with it, that they are the front runners. But then if you look at maybe a federally qualified health center or centers that are serving primarily patients with Medicaid or other socially disadvantaged groups, those healthcare systems are going to lag behind in being able to adopt AI. So that's another way that you want to think about bias, fairness, and equity, and how do we close these gaps to ensure that everyone has the opportunity to benefit from AI solutions. So I just wanted to address that because I agree that if we do not take steps to remediate on the data, that we definitely run the risk, as the example I've shown you, of causing harm and missing diagnoses in certain groups of people that have historically been excluded by the healthcare system. And therefore, we need to concentrate efforts to really address those biases in the data as well as our human biases.
I think
Thank
that's
you all.
a great point on the data side and the application side as well. What I would note is personalization of artificial intelligence is a great opportunity. We generally do not roll out like a broad foundation model, for example, to every radiologist. We individually train on their specific cases, and we identify their voice and amplify their voice using artificial intelligence. Part of that does potentially create, for example, if you're training on a breast radiologist data set, it will be heavily skewed towards female populations. But that's appropriate for the use case where they have, and you are able to find ways to, compensate for the lower prevalence of, males within that. I would also say with the distributive physician practices that have developed, FQHINs are decently well represented in use, particularly in the radiology space, because they're oftentimes covered by larger practices or groups that deliver the services there that have been early adopters of many of these tools. So that's not clearly not all use cases, but in some we're able to find ways. And as an example, safety net hospitals have been some of the earliest adopters of artificial intelligence, simply because of the need. They are ultimately a community resource that is very limited in scale. So they need to adopt tools that can actually enable them to provide services to larger populations more efficiently, which creates great opportunities for that engagement.
We are getting close on time, and I know Jen wants to talk about the standards at a glance, which you can see on the screen here. If you're a current client, you're familiar with them. If you're not a current client, you will be familiar with them. Um, Jen or Laura just chatted in because we've chatted this in several times. So follow that link. That'll take you right to them. Jen, as you're talking about them, though, I want to give everybody on here a chance to, apart from this webinar, hear directly from either URAC, RAD AI, or Cross Global Consulting. So I'm going to launch our closing poll. You can tell us if you're interested in hearing from any of these organizations, and if you want to hear from them now or in 6 months. And if you don't want to hear from them at all, just don't answer the poll. But I'm going to launch that poll. Jen's going to talk about the standards, and I'm not going to share the results of the poll. No need for everybody to see it.
Awesome. So thank you guys for really sticking with us. We have just a few minutes. There are a few things that I want to pull out because they were important to a lot of the things that we discussed today. So while I am talking through some of these points, please note that what I'm saying is not a complete picture of the program. Download the standards at a glance. You can also buy the standards from the store if you're looking for a more holistic view of the standards. So when we started talking about everything, we talked about risk analysis as one of our processes for helping understand disclosures. We actually start even before then looking at impact analyses, scalability analyses, and technical analyses for the system as a whole, within whether it's on the developer side or the user side, looking at those analyses. And that does include the business continuity plan, what would happen if the system fails for you. Also, we talked a little bit about the concept, not a little, a lot about the concept of bias and different ethical conundrums that arise naturally through artificial intelligence and do arise anyway in healthcare across the board. One of the primary things that we did to try to help bridge that gap and really analyze and assess whether or not certain biases are appropriate versus inappropriate, if there's different biases that are being introduced, whether and it could be even personal biases or healthcare system biases. We wanted to include an ethical leader as part of the development or the overarching use of the system. Somebody who is responsible for looking at the system from an ethical perspective and helping make determinations on what to do with that system and how to use it appropriately. Next slide for me, if you will. We also split additional standards into the developer module or the user module. So what you saw on the prior slide was all of the base foundational standards that are required regardless if you are a user or a developer who is seeking AI accreditation with us. From there, then you also have to choose whether or not you are a developer, a user, or you're both. You've developed your system and you're using it. That could be the case as well. On the developer side, you'll see that disclosures is going to be the top thing that has the most standards and requires the most amount of information. While we do also talk about the AI system build and data management, so making sure that you can speak intelligently to your users about generally how the system was built and the training and the data that went into it so that they can see the intended use, the ethical development and use, what data features, the testing, all of those things. You can tell them about that in such a way that would help them determine if the system is appropriate in their setting. And then there's also the user module, which a lot of it is user training and making sure that there is a responsible use of the system, as well as talking about disclosures of use to patients. So I'm going to stop here because we are right on time. Thank you, everybody, for joining. I'll pass it back to Lisa to close us out.
Thank you, everyone. Normally, I have a closing question. Shakira and Dimitri, in 2 words, what are the wins we're looking at in 5 years in healthcare AI?
AI is being used to close gaps in care that haven't been able to be closed in many, many decades.
2 words: reinvention and reinforcement of processes. Like, I think we've got a great chance to reinvent how we do a lot of healthcare in a great way.
Awesome. Dimitri, Shakira, Jen, thank you so much for joining the URAC team along the way. It's been wonderful to work with you.